So welcome everybody. Thank you so much for joining us today. You know, it's just a space where we're creating for women just to talk about menopause, midlife, and whatever else that comes with it. So I'm Dr. Nikki. Please call me Nikki. I'm a medical doctor, epidemiologist, and a menopause coach. Together with my daughter, we founded Lean Flowers Healthcare here in South Africa, where we aim really to support women as they go through their reproductive journey and, of course, beyond. So Ruba focuses on younger women while stepping into our wisdom as mothers, sisters, aunts, whilst I really focus on midlife and beyond. So I hope you can hear me well. And just to start off with, I think just a little bit of an explanation about menopause. We call it menopause. However, technically that's not correct because this is the season we are in. So it makes it easy just to say we are in menopause, we're in menopause. However, there are different phases to it, right? So we've got perimenopause that happens before you get into menopause. Before you are said to be in menopause. You're only said to be menopausal when you've done 12 months without a consecutive period. We all know what a menstrual period is, right? And then after that, once you've done those 12 months, then now you're in postmenopause. So we just call it menopause. However, you know, technically, as I said, it's not correct. So the perimenopause phase has historically been ignored, yet that's the time where a lot of havoc really happens in our lives. And for those who've lived through it, you understand what I'm saying. So remember when our moms, our aunts were endlessly complaining about backache, sore knees, sweating a lot, you know, and we used to just look at them and like, really, what's happening? Actually, guys, that's us now. We are those people. Our children are looking at us and they don't really understand what's going on. Moreover, we don't even understand it ourselves. Hence, we're here today just to unpack a few things around it. So all these things actually happen way before the period starts. So, you know, people, you know, as we grew up, we thought that it was just going to be, you know, my period has stopped, I'll have a little bit of hot flashes and then boom, life goes on, we're good to go. But actually, that's not the case. We go through this phase called perimenopause, which may even start when you're 35 years, and it's got quite a lot of symptoms. And my medical, my medical colleagues, whichever fraternity they work in, actually will agree with me that, you know, we spend so many years training as doctors and specialists in our different fields. However, that lived experience of menopause has humbled us. It has really humbled me. And there are so many symptoms. Women present in different ways, such that all the solutions are actually not a one-size-fits-all. So medical management for the doctors here actually know that if you do something with one person, one patient, you can't do it necessarily with the other. And also, you're also worried about cancers that are happening as women grow older. What is it then that's happening? How do we move through it and navigate and try to understand what is happening with us? So my journey was nothing short of drama. But I resolved that I want to support women as they go through menopause, midlife, no matter how subtle or outrageously loud their symptoms are. So how can we move through the last half of our lives with joy and laughter, with minimized misery? Because we have to, you know, just own it, guys. We are in the last half of our lives and we just want to move through it joyfully, understanding what is happening to us with knowledge and an understanding of what we can do that serves us where we are. So knowing that life is also for the living and that struggle does not necessarily bring rewards. You know, we need to meet women where they are and support them to get where they want to be based on their circumstances. So that's what we do at Lean Flowers. And, you know, we know that life is not only physical, it's also emotional, psychological, and also spiritual. So how do we bring all that together to help me as I move through my life journey, the last 50 years or so of my life, if God permits? And therefore, you know, I thought it's great for us to give guidance to things that we love, whilst also being cognizant of health and our current situations. So, for instance, if you love wine or alcohol, what are the health conscious ways of drinking based on the situation you're in right now? you know. If you love running marathons, because I know marathons are a huge thing now, are you doing justice to your body as you move through midlife? What can you do to preserve your joints, your muscles? Because we know we lose all those things. Or are you just continuing to run as if you're a 30-year-old? If you are in a marriage and this has been a painful thorn, right? How do you find joy in that marriage, right? How do you then, figure it out and say to yourself, you know what, I'm finding my happiness where I am. And of course, if you want to leave the marriage or the partnership or the relationship, how can you joyfully do so? And then the last bit that I thought to highlight is that, for instance, another example is that if you have no sexual desire, or you are in that percentage of women that has not experienced an orgasm, how can we get the door fired? Those are some of the things that we help you with at Lean Flowers and bring you, all these evidence-based solutions so that you can move through your life with a lot of, joy, as I mentioned. So we pledge to forge positive visibility for women in midlife, and we endeavor to increase your knowledge and understanding, of evidence-based practices that will ensure that you have a good day-to-day living. So for many of us, menopause has reshaped us, both internally and externally. And the obvious one is what? Our weight. So that's why we're here together today, just discussing this with our expert who's going to help us with answering some questions around weight management in menopause. Our body shifts, energy changes, and then, we need then to find out what the truth is around weight in menopause. So today's conversation is really bringing together two worlds whereby, Lean Flowers is coming from the point of lived experiences of women who want to ensure that they have quality of life through evidence practices, together with MyTano, a doctor-led platform offering current evidence-based advice and non-surgical treatment options for women and people who want to manage their weight. And when we talk about, MyTano, it's just the holistic approach they have for us. And we are really privileged to have Vimbayinaishe Kandeke, who's at the heart of MyTano. She's a bariatric physician with 23 years of clinical experience, includes a decade of adult weight and metabolic disease management, a clinician who champions new compassionate standard of care, someone who builds powerful partnerships and, between individual patients and client and clinical teams. She's also an advocate for digital innovation and founded MyTano to deliver the bespoke doctor-led support she believes that every patient deserves, each and every one of us. So today we're going to have that insight around weight changes in menopause, weight management, as I said, talk about GLPs, we'll touch a bit on that, hormone therapy, behavior identity, emotional well-being, and some practical steps that we can take as we move forward. It's about really changing. It's about looking at the knowledge and understanding what we need to do without fear. So before we start bombarding Vimbai with our many FUPA questions, because we do have FUPAs, this is an informal webinar conversation, which is relaxed and designed to foster genuine interaction. So please don't feel pressured. Go get your glass of wine, your cup of tea. If you're eating, please continue to do so. If you're cooking, please do so, right? And your mics and cameras are switched off. Please use the chat to post questions and comments so we can get to them at the end of the session. And of course, use emojis to show your reactions. I think it was Gaynor who just clapped for us. So thank you so much, but feel free to do that. This is our platform. And also suggest topics that we can actually then use and, for more, trying to give you more information. As I say, from the bottom of our hearts at Lean Flowers, that is our aim. We want to ensure that we have got knowledge and understand what we can do. So before I move on, I've got a few things that I want to give you. How many of you have gone into a room and completely forgot what you wanted to do? Why am I here? Oh my goodness. Or even forgotten your kids' names. So I'm going to send you a clarity restoration tool with tips on how to steady yourself when you struggle with forgetfulness, brain fog, especially at work. Imagine you're standing in front of a crowd. You need to say things you've forgotten, the word that is called the word clarity. Imagine. And then it is part of a bigger plan, and I'll give you a link if anyone wants to buy, to purchase this full digital tool. It's a planner for, your day-to-day living. And I also have books from my beautiful friend, Jackie. I had 2 books. She's written this, and I am going to, yay, Jackie, you can see her, she's on the call. So I'm going to give away this one. It's called Unshaken, Faith in the Midst of Life Storms. So I'm going to give this book away to someone. Please, Jackie, can you please post in the chat where people can buy these books? Because believe you me, this actually helps. This talks Jackie and her infertility journey and how she ended up now having 2 beautiful boys at 45. So please just, help, just purchase these books. She's going to send through where you can buy them. Next session, I'll be giving this one out, but this time we're giving the first one. So thank you so much for the reactions there. So, Vimbai, hey girl, how are you? Who would have thought that, as we were growing up, we were playing Mahumbwe. I don't know if people know what Mahumbwe is. We, as kids, we're playing Mahumbwe. Who would have thought that would be here? Talking about menopause. Imagine, we were like 5, 6, 7. So thank you so much for coming through, to talk to us about menopause and your vast intelligence and knowledge and evidence-based practices that you have. So let's just start off by you just telling us a little bit about your founding vision, because I think that is very important for us. So that we can understand where you're coming from, where you're going to. What made you decide that weight management needed to be the core of your offering at your practice? And what does this mean for us as menopause women? Yeah.
Thanks for that. Let me just say, I'm really, really grateful that we've got this platform. It's something that I've dreamed of for a while, where we can have a space where we as women can have a chance to talk about the things that bother us every day. I have this conversation multiple times a day with women about their weight, about menopause, about this or the other. So, but we don't have open spaces where we can all share and get meaningful advice and tools out of this. So I'm really grateful. Speaking on MyTano was coming a long time from the time probably I was starting med school. In the sense that there were elements of patient care that I enjoyed. My favorite tutors and all were the people that had fantastic bedside manner. I loved the ones that made human stories out of all our patients. And it's something that stuck with me, that all these people that we see, all these conditions that we see, actual people. So one of my tutors mentioned that when you meet a person in a hospital or in a clinic, that might be the worst day of their life. They're dealing with something that has been really bothering them. So approach people with that context that this could be the worst day of their life. So it could be the worst few years of your life. It could be the worst decade of your life. Clearly, a lot of us are dealing with things. So it's lovely to have this opportunity to talk. So with MyTano and why weight management, it's the one condition that I think unifies all clinical practice. It unifies us all as individuals, men, women, children, the West, the East, us in Africa and everything. We're all dealing with this because of the metabolic issues that come from our weight. So it's not just a cosmetic thing. Unfortunately, it's being made to be a cosmetic thing more and more. We'll talk a little bit more about that. But it's the one thing that touches on why I wanted to be a doctor. So it gives an opportunity to touch on all areas of medicine that obviously you enjoy. And if you're a doctor like me who enjoyed multiple areas of medicine, this is the one for you.
What gaps do you see around support for women, as we grow older? Do you think the doctors are able to support us? How do you think, we can support each other as medical doctors to make sure that our clients, these clients who are on the call, are able to be, to reach their weight goals or see themselves as they want to, or even get to the point of accepting that this is where I am and I need to do something about it?
So I suppose the biggest gap comes from understanding what menopause and weight gain is in general as a start. I think once we understand why these things are happening, it sort of helps us come into solutions and where we're missing the point, both as clinical teams and even us as individuals trying to deal with these concerns.
Mhm.
So understanding we've menopause has been deemed almost a behavioral concern, and weight gain has been deemed almost a behavioral as well and a cosmetic concern. But that's where the start of this gap starts.
Yeah, yeah.
So it's a biological, it's a physiological concern. We're talking about hormonal changes that have real metabolic concerns for us. So if we understand that in this area, this space that you nicely defined as the perimenopause, which is probably the 4 to 10 years before you actually get to the menopause stage, and which can range in years. So we're talking about some people getting into their early menopause at 35. So that could be as early as 31 for some people. So, and then the thing is, we all think we're too old because we imagine some old lady who's in menopause when we think about menopause. But it's the perimenopause, which is what we are a lot of women are living through. So this period in our lives is marked by changes in our two exciting hormones that we talk a lot about in the early stages of our reproductive lives as women. So I would like to assume everybody's heard about estrogen and progesterone and all the fantastic things they do. So you may have heard about it in your pill, in your talk about pregnancy, and you talk about periods and all those things. So these hormones support our reproductive lives as women, but it's not just to do with having children, having periods, having children. It also supports all areas of our metabolic being, which is something that is not discussed enough or addressed enough as a start. So in terms of our clinical side of things, we could support women in understanding that this is something that they're not choosing to go through. It's not something that they're choosing to do. It's something biological and physiological. And then there's more and more evidence as time goes by about the metabolic concerns. So it's not a reproductive switch, it's a metabolic switch. So we are moving into a phase of our lives where how our body functions metabolically, how we are distributing weight, how we are managing our appetite, our cravings, how we're sleeping, how our moods are regulated. All those things come in the perimenopause, and the gaps therefore are not addressing those issues, or even us giving ourselves grace as people going through to understand that this is not anything you've done differently as a person. You're not doing anything unusual. It's just you reacting to the body that you have now.
Yeah, definitely. So what are the biggest myths that you encounter about weight gain in midlife? I just want to know, because women there are saying that now because you're not going on a period, so now all that blood is accumulating to become your that fupa that you have. I mean, so what are the myths that you have, and can you help us to just understand to just dispel
all many myths that surround this? And I suppose the first thing I would say is the biggest myth is you need to be doing more. Let's start with that one. More exercise, more supplements, more detoxes, more this, more that. That is not true. So when you mentioned the fupa, I think the Shona people would know about Chimimba Mtekwe. I think if there's any who are not Shona and they have got away, they call it in their own languages. But I suppose we need to define what that is, isn't it? So we talk about fupas, that's the fat upper pubic area. We don't mention it in polite company, but that is what it is. So we've all seen it. So that actually is a nice symptom. So it's not, what we then don't realize is it's not just the pubic area that's getting fat. It's our whole, so inside our organs, we with this what we call visceral fat as doctors, where so we normally have some fat around your organs to protect them, and they've got some effect as well on managing hormones and inflammation and all those things. But with that change in progesterone and estrogen that we spoke about, so progesterone and estrogen, they promote what we call a gynoid distribution of fat, where you've got fat going to your hips and your thighs, that beautiful Coca-Cola body that we all want. That is progesterone and estrogen. So
Uh-huh.
then these hormones give up on us at some point, and we become more android. So we become a bit more straight. So instead of having the fat going to our hips, is going into our abdomen. So what we call abdominal fat and visceral fat. So it's not just that one obviously is something that's traumatic to see for anyone, but it's a symptom of generalized change in how our fat is distributed. So one of the myths surrounding that is people think that you can just spot treat that fupa, get rid of that. That is a fantastic myth. All the crunches you can do, all the jogging you can do, all the teas, all the injections that you can get. Even liposuction doesn't save you from the rest of the effect of this central weight fat distribution. So that's one of the myths. So, and then when it comes to, I think one of my pet peeves obviously is things like detoxes and all this push on supplements, which sort of circles back to the discussion we talked about gaps in care. So we as doctors, unfortunately, have taken a back seat, or we've been given a back seat on this metabolic concern that we're dealing with, where now there's this open gap, people who are making money without the evidence-based advice, because there's a lot of desperate people who want to actually, so like you're saying, you're dealing with this on your own and you're trying to fix it. The next bit of advice that sounds like it might make sense, they'll give you a little bit of scientific knowledge in there for it to make sense, and you'll jump on it. And unfortunately, there's no sounding board to say this is the right way, this is what this means. It's not supported. We don't have, when you're pregnant, you've got your clear channels of care. You're going to see your obstetrician, you're going to see your midwife, and they will give you answers. You can talk to them. But when it comes to this perimenopause, you're really on your own. And we are picking up from TikTok, we're picking up from YouTube, we're picking up from the discussions that we have in our, I've tried this and that. So we could have a whole discussion on these myths. So but I've heard it all.
Yeah, I can imagine. And now you think about it, you're like, so what did our parents do? What did our mothers do? And as I mentioned before, these complaints, as we were growing up, anybody will say, you will remember, your mom was saying this, your mom was saying that, and her mood was shifting. Everybody was just looking at it like, huh? One person actually said, this is where that issue of mother-in-law and daughter-in-law comes in. Imagine we are getting into our perimenopause and menopause just as our kids are getting married now. They're bringing our daughter-in-laws into that. And our shapes and everything, our body has changed. And now and we don't have anybody to help us to manage that. So now let's talk about your approach at MyTano, right? So clients come with a lot of issues, right? And not only physical, and there are also financial issues that affect us. And at the same time, we're having teenage children, or our children are actually getting married, and we're getting daughter-in-laws, son-in-laws, and then we're also dealing with our aging parents at the same time. And then, of course, there's the relationship issues. I talked about that a little bit, so you're in the middle of that. And as a woman, particularly here for some of us, if you're brought up in the African culture, you are brought up with struggle, thinking that if I struggle so much, I'll get a lot of gains, So MyTano combines medical assessment, behavioral support, and personalized treatment plans, right? Why is this multidimensional approach essential for menopausal women?
Okay, so let me blanket this by saying MyTano is not just really dealing with women in their menopause. The issues that we're discussing here are true, and some of them are specific to women in their perimenopause and menopause, but a lot of them really do affect men, all the children. So we don't deal with children, but so from about 18. And so in the different stages of their lives. And so what our approach is understanding each person as they are and who they are. I think that sort of gears how you then proceed with the treatment plans. So there's no such thing as, oh, I'm on this weight management program or whatever it is, because that can never be true. We are all individuals with different needs, with different paces of progress, with different driving factors for our relationships with food, our body's biology, everything is different. So you cannot blanket. So I mean, obviously there's some basic scientific knowledge that we would obviously need to have to be able to provide the service, but you can't apply it to every person.
Yeah.
So what I like about what you've just discussed now is coming back to the perimenopause. It's a pressure point in a woman's life, like you mentioned. Our careers are at that precipice. So you are at the peak of it, beginning to lean over to the
and you're finding yourself in meetings,
So you're also dealing with that pressure, and then dealing with the pressure of your own biology. You're dealing with, as you're saying, relationship concerns, children, these changes that are true and real to you as a person. Or this was never me 20 years ago, 10 years ago, 5 years ago. And where women come and they'll tell you, I've tried everything that I've tried before, nothing is working. What am I doing wrong? So what the instinct is, let me try more. Let me try more. Let me find more. What is it? I'm sure there's one more thing that I can do that will work. There's one more thing that I haven't tried. And sadly, in this pressure point is other women in this pressure point who are also a voice in your ear. I think women are there in each other's ear more than anybody else. I think we're so critical of each other. Heaven knows why. We're all going through these things. But sometimes I suppose it's, where you're likely to notice another woman's weight gain and voice it, as opposed to being compassionate, understanding, I probably am going through the same thing. Maybe I look a little bit different myself.
Where am I also, but you just see someone else's issues rather than trying to internalize it, to come to you. So then, let's talk about medications now. Yeah. So how do you determine whether, weight management medication is appropriate for a menopausal woman or any person for that matter, and how do I address the growing interest in the GLP-1 medications? I mean, this is a huge interest now. India has said they're going to now produce generics, meaning the price is coming down, so they'll be everywhere. It doesn't mean that the doctor who's prescribing it knows what they're doing. Also, that's another thing we need to think about. How do we make sure that we support women around this, and who needs it, and how do we determine all that?
So the GLP conversation is a very exciting area for us in bariatric medicine. There've been many attempts to find medication to treat weight gain and obesity. I think the last amazing thing that we had was metabolic surgery. The gastric bands, the lap bands, the anastomosis, and all those things that we had. So we've had fantastic success on that. And then we've always had medications in the background, many iterations of weight management medications to varying degrees of success and safety and regulation. The things we've been through are a lot, and it's still happening now, actually, because, so you mentioned the dropping patents of semaglutide. What it then has meant is, at least now, I'm excited about that, because then at least we've got more access to regulated sources of semaglutide than we had before. With the prices that we had and the restricted access, people were still reverting to unsafe methods of weight management. Not everybody wants to have a bariatric surgery, obviously, with the lifetime complications that come with it and the lifetime support that you need with that. So this felt the introduction of GLP-1. So what we're calling GLP-1s is glucagon-like peptides. So it's medications. These medications mimic hormones that we have in our bodies. So it's nothing unusual. So everybody makes GLPs, not GLP-1s. They make GLP-1s is the receptor that picks up these hormones that we make. So we all make this hormone. What it does is, when we eat, the circulating glucose that we have in our bodies triggers the pancreas. It tells brain cells, tells the intestines, the stomach that, oh, we've picked up some food here. The pancreas is busy making insulin to deal with the glucose. The brain is excited because it had realized we were hungry, so we've now given it something. So what the GLP then comes in to say, okay, I've seen that you fed me. Tell the brain to stop thinking about food. We're done. Tell the brain to stop telling my arms and us in this food-seeking behavior. We're done. Thank you. So we then feel full, and you get to the point where you're like, oh my gosh, imagine you've been to a Christmas lunch or something. You're like, I couldn't possibly eat another morsel. I can't even look at this food.
Yeah, I'm done with this food.
The brain is
right.
And then it also tells the pancreas, okay, thanks, we're done with the insulin that you're making. Let's just now finish storing what we're storing. And then it picks up what levels of glucose are left in our body. And then it also tells the stomach to slow down so that we can digest what we've eaten. So you then feel kadumbuke, yes, that's GLP-1 telling everything to relax so that we can digest, and then we can start absorbing what we need to absorb. So the GLP-1, so obviously this hormone that we make in our body doesn't last all day. It doesn't last long. It's just enough.
Okay.
So what these medications then do is prolong this effect. So what we're then doing is we're managing our sugars better. We're slower to get hungry. We're quicker to get full. And we're able to manage our cravings better because our blood sugar levels are steady. So now back to the deciding who needs this medication. So this is now more of a clinical decision. So this is a medication to treat a condition. So which again circles back to obesity being a disease. We finally won the cause to have it deemed a disease. So that's a big plus. So
yes,
what unfortunately has happened is there's been another gap where people have looked at these medications, one, as a cosmetic fix, two, because of their restricted access, it's only been accessible to a few here, there, and there. So hopefully this will, and we'll begin to look at it more as a drug, as a medication, as we need to.
okay.
So like all medications, we need to have a diagnosis for us to decide I need to prescribe this medication. So how do we diagnose obesity in people? So when we use the word obesity, people seem to think of this person, I think we've watched My 600-Pound Life, we've watched all this, and they think it's somebody who needs to be carried. I recently saw a lady who needed to be carried off a plane and things like that. That's what we imagine when we use the word obesity. But obesity, well, it's a clinical number really in terms of what your BMI is, what your metabolic health is doing, and then more importantly, now we're using what we call the waist to height ratio, which is a bit more, it's a step better towards understanding the metabolic concerns with weight gain, much better than BMI. So simply, really, waist to height ratio is just that. You measure your waist. I think in centimeters. You measure your waist in centimeters. You measure your height. You do your height, your waist over your thing, over your height, and you need a number that is under 0.5 to say you're healthy.
Okay, we've learned something new, ladies. I don't know the others will do this. I don't know if it applies to us. Yes. Okay.
So it's a nice number to use, and it's a more reflective of the metabolic concerns. So we spoke a bit earlier about central weight gain. So the reason why we want to treat weight gain is we want to prolong our metabolic health. So this central weight gain then comes with cardiovascular risk for things like hypertension, heart disease, lipid problems, type 2 diabetes, you name it. We're talking about effects on our lungs. We're talking about all these things. I mean, that's a whole other talk about the effects of obesity, which are real medical concerns which is why then it brings in all the other specialties that we're talking about. We're talking about psychiatry, obs and gynae. Everybody is currently dealing with the effects of obesity.
Yeah.
So once we've deemed a person to be, so we've got a sort of a few cut points, and then also it's individualized for who you are genetically. Okay, so I see a lot of women of African origin and men of African origin. So there are things that we all know run rampant in our community. So we're talking about things like hypertension, type 2 diabetes, and that sort of thing. So we've got accommodations for people of certain genetic makeup, and indeed anybody. So once you've got those metabolic problems, our threshold for treating you is lower, because we obviously want to manage complications, which is the reason why we treat people anyway, which is why we are all excited about these medications, because we now have another step that we can use. So what we then do, we do a full assessment. So we spoke about the history taking. So we talk about meeting this person and getting to know who this person is. We examine you. We also want to know what your blood is doing, what your metabolic profile is doing, what your lipid profiles are, what's happening with your kidneys, what's happening with your liver, all those things. These are all steps we're taking to try and decide who is going to be okay to take this medication. We also do a general assessment of your current medical profile. What medications are you on? What contraindications do we have? What's your lifestyle like? And then you also mentioned about financial concerns, because unfortunately at the moment all these medications are self-funded. So we will also want to discuss how you intend to pay for your treatment and all those things. So the assessment is vast, and it's not a 1 hour assessment. It's, as we've noticed, all the issues that need to be addressed. And then we're also looking at your food habits, your food. There's also food diagnosis. You've got a movement diagnosis. You've got mood diagnosis. So there's a lot that comes into deciding who is going to have this medication.
I love it, because it's a holistic approach. And as I said, we meet a person or a woman or a client wherever they are, rather than for them to come to where we are, help them to get to where they want to be. And I believe, this issue around obesity being now is being deemed a disease is a game changer. It's a win. And now we have all these medications also, So now, in terms of now sustainability around this, what does this mean when you start these medications? Then what? Because now we've seen, and TikTok again, social media says some people have stopped, but then once they stop, we are back to square one. So what are we going to do? And then we also heard some people, some doctors actually then prescribe the maximum doses.
Yes.
How do you then say to us, no, this is where you end? Because we do know that it's not a one size fits all.
Yes. Absolutely. Absolutely. So you've touched on quite a number of important issues in this question. So the first starting point would be one size doesn't fit all.
Yeah,
it really doesn't. So even where we start off, so we obviously have, so the idea with these medications is you escalate the dose based on what each person needs. The unfortunate thing that happens is people think that you need the maximum dose to get the best effect and the quickest effect. So, which is another, I should have added that to the other myth that or the trouble that people have is, I just want it done now. I want to lose the weight now, and then I'll stop this treatment and I'll be done. So we did mention that this area of your life is a transition into a different metabolic being. So you're a new being, new metabolic being with new concerns. So even things like the hypertension and all these things are probably a part of who you are now, genetically, metabolically, and all those things. And everything that we do is to try and help mitigate all the complications that you can get from these conditions. So I do not like the idea of, when am I going to stop the treatment? We did mention that obesity is a disease. It's a chronic disease. By chronic, it means it's not something we're going to cure. It's something we can control. So I'll give you examples of chronic diseases: hypertension, type 2 diabetes. Those are chronic conditions. So when you are given medication to treat your hypertension, we're not saying, take this for 6 weeks and you'll be fine. Because yes, the moment you start taking the medications and we found the right dose for you, again, even those medications, it's not the same drug for everyone. It's not the same dose for everyone. You have to do an assessment. I mean, I treat a lot of people. I treat a lot of hypertension, obviously, in the nature of disease that that I'm working in.
Yeah.
You are trying different doses. You're trying different drugs. And you then find something, but then that doesn't mean that's now done. Okay, we found you your 5 milligrams of amlodipine. Bye-bye. We don't ever want to see you again. You're fine. In 6 weeks, stop the medication. You'll be fine. That's not how it works. And it's true for obesity treatment. So I think, because the introduction to the population of these drugs was not done by us as medical people, it was by sensationalists, and this one is making money off it, that's why they're pushing these drugs on us. These are genuine medical tools that we are so grateful to have. It's unfortunate that it's coming at a time when there's a lot of misinformation on social media. Anyone can tell you anything. Anybody can sell anything. There's a lot of wellness gurus. There's a lot of everything. Everyone has got something to say, and they make it so palatable. And so when you come in as a doctor and you are coming in with your clinical approach, I need to make an assessment. I want to make a diagnosis. I want to monitor treatment. I want safe, effective doses. I want to do. You sound really boring. I want to, this is a chronic issue. I want it now. I want someone who come and tell me 6 weeks, you drop 20 kgs.
Let's move.
Buy my tea, you'll drop all this weight and stuff like that. So
it doesn't work like that.
So understand, I think what I would love everyone to take home today is it's a chronic condition. Okay. So so the medications that we use are tools to help us to deal with this condition. They're not the end all. They're not the be all. We're happy they're there because they can help us to take our treatments a step further, and our success rates have improved so much more because of these medications. And it's safer because we can now do things that we could only do with surgery before. So imagine that, how much cheaper, how much safer, how much more access it is for everyone.
Yes.
So that's one thing, understanding that it's a chronic disease. So yes, to answer the question, when people stop the medication, they gain weight, but that's only in those cases where you've not done the work to deal with all the other. We've spoken about a lot of other things around weight gain that need to be. So we're talking about food behaviors, personalized food behaviors. We're talking about your body's response to these hormones, your body's everything. So which is the work that we do. So I can tell you safely, I've never started a patient on weight loss medication on meeting them. We don't operate like that because, again, you don't walk into your doctor's office and they say, oh, you've got hypertension today, here's a prescription. So you still need to do an assessment. You need to know how safe they're going to be. And you need to know who's ready to take this medication. Not everyone is ready. So all these things, so there's years and years. By the time you meet a person in their adult years, they've tried all sorts of things to lose their weight. They've got beliefs that they have about how they eat, how they manage their weight, what has worked for them before. So you're sort of unpicking a lot of history, a lot of emotional attachment to food and food behaviors, a lot of emotional attachment to how our bodies are, and the stigma that comes with weight gain, the trauma that comes with it, and even just the time constraints that come with trying to deal with all these things. So it becomes overwhelming. So you're not going to get onto the first encounter and say, we're going to do A, B, C, D, D, because the prescription is very long. So if you do all that work and the person decides to eventually stop their treatment, this they can. Like, you can stop your treatment for anything, it's up to you. But what I find certainly with MyTano patients, when they stop, if some that have stopped their treatment, because you've done all that work with them, they've done a lot of work themselves to get to the point where they've lost their weight, they've met their goals, they've been sustainable, they've done all these things. They will never be that person that they were when you first met them.
Okay.
So a lot of things have changed in between. So even if they do gain weight, they're not getting all the weight back. And the truth is, as they gain some weight back, you're still there to support them and help them to wind back things a little bit. So I think the important things are understanding it's chronic, understanding that there's support, and understanding, give ourselves grace. You know, it's not something you're going to cure, it's something you can manage.
Yes, absolutely. It's very true. And then, there are issues around hormone therapy also. Do you want to touch a
Yes.
little bit on that? And also around, we've spoken about weight gain in menopause. It's just not physical.
Mhm.
It affects the identity and confidence and relationships. Maybe we can also touch that on that. What do you do at MyTano to support people, or more specifically, women who are in menopause? Yeah.
Okay, so women in the perimenopause,
Yeah.
we're all learned colleagues now.
There's everybody, yeah, everybody knows now, eh?
So
Yeah.
women in the perimenopause, like we said, we touched on all the pressures that are on women. At earlier we managed to. So it, like we say, it does touch on people's identity. We identify ourselves. Obviously, when you look in the mirror, this is me. This is where. So people start saying, I'll say to Shona, "Pane tunyama tubungo muka muka tunyama." So you start getting fleshy bits like you don't know where they came from. It affects your identity. It
Yes.
affects your sexual health and your confidence. It affects relationships. And then we're talking about hormonal changes that are affecting how your sexual appetites, your perception of your partner, which is also affected by life's pressures and all those things. You had this long day, maybe you're not interested in that, or indeed maybe you are, but maybe your partner isn't because you've had all these changes yourself.
Yeah. So a little, it's cycle. That
It's
is
a
just,
vicious cycle, yeah. So you
yeah,
spoke about, you asked about menopause hormonal therapy. So this is also another tool. We mentioned GLP-1s as a tool. This is another tool that's available to us. And what happens with it's hormone therapy has had a lot of bad rep.
yeah,
I'm sure you'll agree with me,
yeah,
where you spoke about cancers and all those things. So I think in unsafe hands, you've got risks that come with use of
yeah.
and then we also have different types. I mean, we live in 2026. Oh my God, the
And
options are endless. I'm so proud of us for being alive in 2026. So
yes,
you can choose local therapy, local hormonal therapy. Some, you're talking about, oh, you know what, my skin is drier, I'm feeling this way. You can do, there's things you can do to help with that. I've got vaginal dryness. There's things you can do locally that's not going to affect the rest of you.
yeah,
There's and in those things, we've got different types that will work for every different person. There's some people who want something that they can just put on and forget,
yeah,
pretty much like they can do with their implant or their loop. Some
yeah,
want to have a bit more control and all that. So and then you've got obviously the systemic, the ones that you take inside, the tablets, the injectables, the patches, and all those things. So it's again patient selection. I will call it patience, but I suppose person selection
yeah,
for what works for each person. And then again, some people don't, not everyone needs therapy, hormonal therapy, because sometimes I find that when you go through all these discussions with people and they understand why it's happening and they anticipate what's happening and they're calmer about what's happening and to anticipate what's coming, they deal with it,
yeah,
and it's a phase. It's not going to be, this is not going to be you forever dealing with these vasomotor symptoms, the hot flashes and everything. That's not you forever. Or
yes,
what can you do to do it? It's not you who's going to be dry forever and stuff like that. So there's a lot that comes with the assessment and the understanding of each person's needs. So not everyone who comes to me for weight management wants to be on GLP-1s,
yeah, yeah.
but there's things we do to treat and support everybody. So person selection so each treatment for each person.
Yeah, yeah. I think that is very important, because if anything we take out of here, if your friend just tells you that this is what worked for me, this is what, and you think you're gonna hop on that horse and get the same outcomes, not necessarily, because you're different. You've got a different genetic makeup, you've got a different lifestyle, you've got different stressors, because stress also comes into the
Yeah,
story around,
absolutely.
weight gain and all these things. So do you have some examples or anything that you have to tell us what successes you've had, so that people know that there is some success? We don't want names or whatever, but just some numbers.
It's not some success, there is success. Let's leave it at that. So
So say success.
I
There
think
is-
let me say this, every person that you meet has a story. Every
yes,
person we meet has a story. We may they and varying degrees of success in terms of weight loss. Some come to you because, oh, my body's changed, I want to change how my body looks. So, and then I'll start by saying that I'm big on non-scale goals for people, because my basis is clinical and I'm looking at their metabolic success.
Yeah.
So let's just say this: every person who goes through treatment has some success depending on what it. So sometimes we come together, we find success that we all can celebrate. And the truth is, there's no way we're going to get metabolic success without the scale changes that people tend to focus on. But what I've enjoyed as one massive success story in terms of the patients we see is the shift in their attitude towards what they find as successful weight management treatment. So every time you meet a person, and it's like, well, you meet the same person over and over again. They come to you at the end of the body habitus is different when they come into my office. When I used to have in person, so now obviously I'm digital completely. They come, how they dress, you can tell. So after some time of treating them, they start coming in and you're like, you've got style. They start wearing their outfits. You start seeing them in their tights and in their heels. You start seeing the makeup and you're like, oh. So for me, so those are some successes as well, how they see themselves, how they present themselves. And then obviously everybody wants to talk about their scales. This is so when it comes to treatment. So when we combine the interventions that we talked about, all the other non-pharmacological, so the non-medication thing that we're doing, we talk about psychological, we talk about nutrition therapy, we talk about movement therapy, all those supports that we do. And then for some patients, we also add the pharmacological aspect, the medication. So if you're looking at it in the sense of you're doing all of those things with the medication, you're getting success that is comparable to what you'd get with the extreme forms of bariatric surgery. So for example, we're talking about, you'd have to obviously know the starting weights. Say, probably somebody started at about 100 kilos. After about maybe 18 months of treatment, they're down to, say, 62 kilograms. That can happen. Some people are not looking for that drastic a weight loss, but obviously we're monitoring what's happening. So we're looking at, so we talk about percentage changes. We also have to have clinical measures. So what we talk about generally, I think our doctors in the mix would understand, if you're talking about the first 12 weeks of treatment, for you to say this treatment, whatever it is, the treatment that you're doing for weight management, you're talking about, oh, a person's lost about 5% of their body weight. So you at 80 kilograms, we're looking at you to lose at least 5 kilograms within 12 weeks to say this is completely working for you. And that happens. But then people generally tend to lose, we're talking about 10 to 20% of their body weight. So you do the math, somebody's starting with you at about 80 kilograms, 10% is about 8 kgs. So we sort of expect that sort of range. But I don't like to put numbers like that on people. We do discuss it. But then it's almost like you're giving people a target that they should, which then almost makes the one size fits everybody. So we set targets based on each person, because I also want to know what do they expect. Maybe some person is not happy at a BMI of 25. Especially if we look at women of African origin, they don't want to be at BMI of 25. They don't want to lose their curves.
So at the end of the day, we're talking about a patient's goal. Where do you want to get to, and then you help them to get there, because safely, yes, please, and also the thing is, you're looking at yourself in the mirror and you're like, oh, I need this one to go. Some things may not necessarily go, but it's now getting to a point of looking at your body image and also trying to get to the point of saying, this is who I am. How can I dress? How can I now put the makeup on? How can I,
Actually, Nikki, on that point, if you've lost weight, you're not going to keep the fupa. You're not going to keep all the adipose tissue reacts the same. So there's no spot treatment. So if you liked how you, and we also have our general body body shapes that are meant for each one of us. So you'll sort of maintain that. You're not going to suddenly be because you've lost weight.
Okay.
You-
Yeah. So you maintain your shape. It's
yeah.
there are a lot of things. I suppose that's another discussion for another day. All these surgeries, the BBLs, and all these things that are happening out there. I mean, as I said, it's another story for another day. But I think this is so good that I love where you're looking at a person as and who they are and where they want to be, and how we help them and support them to get there with all these various tools that we've got. Your story is not the same as my story, and you meet them and you help them out and you support. And when do you get to a point of discharging a patient, a client?
Okay, so I don't discharge my patients.
Okay.
But what we do when we start our treatment, we do a map, so you sort of want to know what their aim is, what their goal is, and you want to know when they are ready. And almost so as the treatment progresses, you start talking about that discharge of care based on what their desires are. I've got patients who are done losing their weight. They're just maintaining their weight, and they decide, what, doc, I want to catch up with you every 3 months.
Okay.
Just what also then happens is they enjoy the discussion. They also enjoy what sometimes what you realize is just because you've lost weight doesn't mean you're cured. There's also things that come up, which is something that I find more and more, where people have achieved their weight loss goals but have lost a certain part of who they were for all these years that they were overweight, and they don't know how to deal with that new person. So it's almost like, oh, now I have to dress differently. I have to buy new clothes, or I look different in my clothes. I don't have my bum. I don't have this. Or who am I without this weight? I could have. So does that mean that I'm this kind of a person naturally? Am I just shy, or was I hiding behind the fat?
This person.
Yeah, so now that I've lost the weight, but I'm still not comfortable stepping out into society, what does this mean? So we find that past the weight loss, there's still a lot of need to support people. So back to your question, when do we discharge patients? For me, any win is a win. A person who's dropped 1 unit of their BMI has gotten closer to metabolic health. We celebrate that. You've dropped a little bit of this. We have so many things to celebrate. Yeah.
To be
So
joyful.
when people feel they're ready to cut the cord, we don't just get to that day and then say, oh, now we are not seeing each other anymore. No. So we start working towards that. So it's part of the timeline that we've created at the start of our care.
Okay, all right. No, that's great. So as we're getting close to winding down and going into the chat and getting what people are asking, please send your questions in there. We'll just get them we will get to them just now. I'm sure some of them we've answered, but what practical steps can women take to manage their weight? What do you want to say to women, right now? Because they came here trying to understand their weight gain. We've told them all that. We've told them about perimenopause, menopause, post-menopause, told them about hormones. Then what? What's the call to action, Wimbai? What do we do?
Okay, so my first point of call is grace. My favorite words today, grace. Give yourself grace. So the practical step is understanding that you've not done anything different. You're not doing anything wrong. This is the body and the biology that you have today.
Hey, this is where
the first practical step is, how do I deal with Vimbai today to get to a healthier Vimbai in the next few years?
Absolutely. Self-compassion, guys.
So now, hopefully, after the little taster of a discussion we've had, the point is, it's not all lost. You're not alone. You're not in the wilderness. You're not supposed to be out there fumbling around in the dark by yourself. There are answers. So you talked about menopause questions. We've talked about weight, all that stuff. So there are clinicians, growing group of clinicians like you and I, who are approaching this in a more holistic fashion. And so you understand that these conversations cannot happen in a 10-minute consultation, which is the limitation sometimes doctors have. You know, I've got 10 minutes to see my patients. I've got 20 minutes to see my patient. How do I deal with this? As you can imagine, getting to the core of each person is going to take, the assessment will go beyond the consultation room, which is again why another discussion about digital tools and why that is such an amazing addition to the care that we can give today. So there's help, there's solutions, but in the process of doing all that, grace, and self-compassion.
Self-compassion, guys. Yes. Okay, great. So I think people are eager just to get their questions answered. Okay. So, Dr. V, where's your practice based?
My I'll say it in Shona, Muma Sai Sai. So I live and work in the UK, but like I said, I run a digital practice, so I see patients all over the world. In that way. So then it depends on what we need to do for each person and whatever. So then we can find different ways to approach their individual care. But yeah, so to answer the question, my physical self is in the UK, but my practice is global.
Yes. So anywhere you are, guys, you can reach out to me. But I'm going to show you, and I'll also send it to you in your emails, her details, where you can get her, you know, but she is available. We are moving to a digital world, telehealth, all those things. It is good. So don't think just because she's not poking you, it's not, she will not get the right diagnosis or help you. If need be, she can even refer you wherever you are. We try and find.
So thanks for mentioning that. So we for effective care, as we imagine, we spoke about different clinicians, that the aspects of medicine. So we do work in a multidisciplinary system. So there are people to help with the mental health. There's people to help with you know, we talk about the cardiologists. We talk about all this. So there's a network we can refer to for specifics. So there's something for everyone.
So there is space, guys. You can reach out to Vimbai directly or to me, and then we'll help each other. Okay, so we've got Erica here who says, great platform, congrats. Nice to see my former med school classmate Vimbai looking great. You know, you were very young then. Hey, menopause was not even, you didn't even think that you were going to get
I'll be menopausal one day.
So my question, I'm always looking to learn about weight management and coping with peri or post-menopause, and not only for me at 45 now, but also because I'm a breast cancer oncology physician, and I put thousands of young women in medical menopause every year, hoping to cure their cancers. My patients in 30s to early 50s struggle the most: sexuality, weight gain, poor sleep, depression, foggy memory. I've had relationships and marriages ruined thanks to breast cancer medication and side effects. Do you have any suggestions and resources for us? Thank you.
Yes, so that is what you've just described in that question is a nutshell of all the different concerns that women have in the perimenopause, and not just in the perimenopause, but even just with weight gain in itself, those things can apply.
Yes.
So there are resources that we can give for obviously the clinical side of things. And what we're also trying to see what we can do is we're trying to set up a series for medical professionals where we can have practical steps. So what you need is a lot of support in discussing these concerns with your patients, helping them to anticipate these concerns, being able to identify them and come to you, and you also then being able to receive them without panic and knowing that there's steps to do that. So there are obviously resources we can use as doctors. There's training we can do specifically, and we're also trying to see if we can do something together so that we can get that. So, but we can be in touch and we can share some of these things and get you. But yes, indeed, there's a lot you can do for them. I mean, I suppose the fact that you're able to recognize the treatments that we give can lead them closer to all these things is part of the word grace. You're being compassionate. Some doctors would do this and not even think this is what's happening. Why are my patients telling me about the sex life? So the fact that you're approachable, I think you're already showing a lot of compassion. So kudos to you, Erica, and I look forward to catching up and we can get into it a bit more.
Yes, absolutely. So, Gaino says, fabulous initiative, ladies. Hoping the platform will provide a sacred space for women to network, support, and share experience as full human beings, and not necessarily in relationship to men. Looking forward to developing more positive and affirming narratives. Absolutely. So, gaps in care and their exploitation. What about, tell us about these gaps.
So we touched a little bit about the gaps in care where people, so we, even just understanding that, trying to explain to people that you can see a doctor about your weight is not something that is traditionally known, or even people are knowing what is a bariatric physician, what are you talking about? People do not understand that and still don't. So
what is menopause coaching? People don't even know.
Yeah, they don't know that these things exist. So where then people, they'll look for information wherever they can find it, whoever is loudest offering an answer. Oh, are you having problems sleeping in menopause? Come and buy my what's the favorite one these days?
For sleeping, there's a magnesium around.
Yeah, magnesium for your weight loss as well. It's also touted as a weight loss.
On.
So the gaps in care come from all this. So I think it's a two-way step where we need the patients or people who are having these problems understanding that it's okay to approach this kind of professional to help me, and I will get appropriate messaging, not just someone who's trying to make a quick buck off me. So, and then all I can also say is, if someone is selling you a detox, someone selling you a plan or whatever it is, I would raise my eyebrows at that. So be mindful. There's a lot of charlatans out there.
People are out to make money. It's difficult. Fuel prices have gone up. So there's an issue around intergenerational conversations from Gain Again. Yeah, and I think for those who follow me on my YouTube channel, we had a conversation with my daughter, Ruba, who's here. Around perimenopause, menopause. I'm actually postmenopausal, so yeah, but the fupa is still fuppering, so so in terms of intergenerational conversation, I think we need that more than ever. We were stuck head on with perimenopause, and we didn't even realize it. Not because we are stupid, but because we didn't know, and our parents went through this. Maybe it's also that issue around the generation gaps. So we will, as from our end, we're gonna come up with some sessions where we'll also bring in our girls. I want to talk to the girls particularly. Yes, we can talk to the boys, but let's talk to the girls so that they are aware and know what this is all about, what it entails, and they will be able to navigate the space, easier, hopefully. Most probably by the time they get there, there'll be other tools. I don't know, the world is an oyster in terms of development in the pharmaceutical side, but also the non-pharmaceutical side, because I also try and understand and make sure that clients get to use non-pharmaceutical interventions for themselves. So most of them are now just comments so much around injections. The injections, oh yes, for fat loss, particularly around the abdominal area. Yeah. Can you just talk to us a little bit about that?
So I did mention earlier that you cannot spot treat weight gain. So there's been a proliferation. Obviously, you mentioned BBLs. This has come from the era of liposuction.
Yes.
So what liposuction does, obviously, is you're physically removing the fat around a particular area, and then with BBL, you're then just injecting it somewhere else where you'd much prefer to have it. But guess what? You still have everything else is. I developed a stubborn bit of adipose tissue on my back. All those things are still there. So it's almost like you're putting a little band-aid on this fracture. So that's basically what I can say about it. And then those specific injections that people want to give the aesthetic clinics to melt fat, to do all that. There's a lot of oil. We'll roll the fat, we'll freeze the fat, we'll do whatever and stuff like that. Just imagine, okay, so even if you did manage to kill that section of fat cells, what about all the metabolically active fat in the rest of your body? So we still need to look at you as a whole individual who's got a disease that's changed the accumulation of fat.
Yeah, I think it's as you mentioned before, this issue around making it a cosmetic issue. You know, what do I look like? I want the hourglass. So now we're going around, injecting little pieces. That's another story, a story for another day. So the question around GLPs forever, we've answered that, right? How can we manage weight naturally?
So it comes to understanding your relationship with food, for example, with relationship with food and movement. And then as we also now approach this area where we need to re-look what we're eating, what proportions are we eating, how frequently are we eating. So some of the things that are happening, obviously, as we move into this phase of our life, because of the hormonal changes, you're naturally moving less, so you've got to be more conscious about your movement. Not only are you just moving, we are also worried about your skeletal density. We're worried about your this muscle loss that comes with the perimenopause, what we call sarcopenia. So you're changing how you exercise in that area of your life. That needs to change. How we're eating, the frequency of how we're eating, what things we're allowing to feed ourselves, and all this. And then so we're also looking at relationships. So by the time you get to that stage, people have had all sorts of bombardments. Unfortunately, food is something that creates a lot of emotional attachments. We attach it to how well we're doing, what's being marketed, what's sexy to eat, and all those things and stuff like that. But we need to then go through the conversation and see what works for you and the goals that you have for your metabolic health.
Yeah, chisanyamas and the like, barbecues there, but
you can have a chisanyama and still lose weight, but we need to figure out how often you're having it, what else you're eating with it, how much of the chisanyama you're having.
Yeah. Absolutely. So is there anything you can do ahead of time to help you manage perimenopause better?
What you can do is how you approach your weight at this age. That's a younger age. Well, I'm assuming there's no one here who's 15 on this group, so you're already past that age.
Yeah.
But in all fairness, what you can do is the relationship that you have to these food fads, diet fads, where to go for information. Be discerning about what information you allow yourself to receive. So not everyone who's claiming to be an expert is not. So you also need to be able to sift through the misinformation that's abundant in the world today. So probably that's my biggest advice is understand yourself, listen to yourself and your body, and be able to pick up the changes as they come and be discerning about what information you assimilate.
And then just looking at the holistic approach for perimenopause, it's the most important thing is to have the knowledge and awareness and understanding of what this is, and again, giving yourself grace and self-compassion when things start changing. Who am I right now? Who am I when no one needs me? What am I going to do? Self-discovery is very important, guys. We lose ourselves as women, particularly African women. We tend to lose ourselves in this.
I think it's sort of to cut in. That's actually a really big thing in the sense that we think no one needs us because we're now useless and non-reproductive, but that's not true. We celebrate all the phases of a woman's life. This is a very important phase of a woman's life because you are now the keeper of all this knowledge. You are the keeper of all this understanding and compassion. And you're also, a lot of us are economically viable. You are looking at, we are also in caring roles for aging parents, young teens, uni children. So everybody needs you. Everybody needs you. So look after yourself, keep yourself alive and sane and available to do all these things.
So can you recommend natural remedies? Because I found most of the NHS stuff causes itchy skin? You know, is it natural? I'm not sure if it's natural remedies for weight
For
loss,
menopause.
or just for menopause.
Okay, not understanding what these products that they've used that are giving them itchiness. I'm assuming this person's talking about menopause treatment.
Oh, amen.
So, in terms of recommending natural remedies, I think as we did belabor a lot at the beginning of this conversation about the hormonal changes and the metabolic changes that come with that. If you understand that as a start, that this is a medical thing that is happening, this is a medical concern that is happening, and then you want to approach it with the gravitas it deserves. You want to find treatments that work, treatment that will do what they say they're going to do and get you to a healthier state. So, so what you're describing there is a side effect potentially to a treatment. My advice is not to dump all ideas that there's no medical treatment that can work for me. Work with your clinician, with your whoever is your prescriber. Talk to them. This is not working for me. You might need a different treatment. And like I said, there's multitudes of options for you. But if you are going to take a treatment, get something that works, that keeps you healthier and gets you where you need to go. The problem with a lot of these natural remedies is they're not peer reviewed, they're not tested, there's no evidence for them. So I would be very concerned. But I say go back, talk about, if you're really suffering any side effects, go back and talk about it. Don't just avoid the treatment altogether.
So my quest, as an epidemiologist, right, is to look at research. There's some stuff out there around natural remedies and the like, and I've been trying to look at what they say works based on, clinical trials and the like. It's nothing really compares to all these medications that we're talking about, your hormone replacement, your hormone replacement therapies, your GLP-1 agonists. There's nothing that compares. But there are some people, because we do know that some people do not want to go down.
Exactly.
So we'll bring in another conversation around this. So next time. So someone says, is my understanding of you correctly to say there's medically weight loss options that can assist that can assist, I suppose, women to lose weight gained due to perimenopause?
Yes.
Yeah.
The simple answer is yes.
Yes. Yeah.
Yes. There are many options now available, and there's many tools available to us, which is an exciting time to be alive as a doctor.
Yes. What can we do to manage bloating?
So bloating is something that I talk about a lot again in my practice, a lot. So bloating comes from two things, and which we will find out anyway in our assessment of you as a patient. Bloating can be hormonal. Bloating can be because of the nutrition, what we're feeding ourselves, how we're eating, and it can also be because of movement disorders. So, and then obviously then there's other gastrointestinal disorders where people genuinely have irritable bowel and things like that. So there are many ways to deal with the bloating based on why you are bloating.
So you touched a bit on back pain at the start. Can you elaborate on how it's linked to menopause and how to deal with it? So let me start tackling it, and then you can take this one. So menopause really, like Vimbai mentioned, dropping estrogen, progesterone. These are core hormones, together with others, that support, our bone structure and our muscle mass. So when you reduce all those hormones, so imagine now the back, it does a lot of work. It does a lot of work. There's a lot of weight bearing and all these things. Even the knees. A lot of women will talk about knees. Hence, I was talking about marathons. Women are still running like crazy, and yet you're not getting the support that you need to ensure that we maintain all that muscle mass, and also just our bone structure, our bone density reduces drastically, especially in the post-menopause. So, it's another conversation. We're going to bring it up again to talk about all those things, how to exercise. It changes. You cannot be exercising as if you were 30. Really, next thing you're going to get a hip replacement because you've broken some joint. So it is what it is, guys. In terms of where we are, we celebrate where we are, but we celebrate also that we've got support for us to have knowledge and an understanding of how to deal with some of these things. Vimbai, do you want to add anything?
No, so you touched on the bone density, muscle mass, and even just the ligaments and everything. It all comes together. And then what also happens, what we can also add in there is you've gained weight as
Yeah.
well with this menopause. That will add load onto this frame already, which can contribute to the backache.
Yeah.
And then also how we're moving or not moving is also contributory. So there's many steps in that little ladder that can help deal with back pain. But the point is, yeah. And then sometimes it also is wear and tear,
Yeah.
which is happening in our midlife.
Yeah.
So we go through, you can go through all that assessment. And then we then spoke about bringing in our colleagues, the orthopedic surgeons, the rheumatologists, and all those things. And sometimes maybe it's just various forms of arthritis. So there's a lot of things that that can contribute to backache. But what I would say is you need a proper assessment and get the right solution for you.
Yeah, yeah. So we'll definitely have a session on that one. So, so say you have already started on your semaglutide on first dose and probably failed to instantly move to second dose as prescribed by the doctor. Will it have effect? Say you move on to the next dose in a month or so. I'm not really understanding this question. Maybe you are. You
Okay.
have.
I mean, the person can type in and correct me. What I'm understanding is, so like I mentioned, that we escalate the dose gradually for
Yes.
semaglutide. So what happens is you start on the lowest. I hope that's what your doctor did. Started on the lowest dose and assessed how you responded to that dose
Yes.
before we moved on to the next one. And then once you've moved on to the next one, you're also supposed to assess and see what happens to you. So what we then sometimes advise is you step back to the most comfortable dose that you were, and then we see what we can do if that was acceptable for you, and then we revisit it depending on where we are. So, but to be honest, that doesn't happen a lot. But I think sometimes what happens is people start on a high dose, and that's when it's intolerable. I've never had to stop a patient because of side effects, in all fairness, after you've done the proper patient selection and proper dose escalation. And then another thing is I've never had to prescribe the full dose of semaglutide, by the way.
Yeah, yeah. Well done. So actually, to close off, there's a testament here. I'm a testament to the benefits of doctor-led weight management, having gone through MyTano, which offers a holistic approach. Not only did I lose 2 stones, but I've changed how I feel, how I feed my family. I love food, but I have a better relationship now. So there you go, guys. Someone came out and just told us, just gave us some evidence to say that this does work. It does work, guys. And we want to support everybody, every woman as much as we can. And also, your outcomes do differ, but at the end of the day, we are here to support each other. So as we close, right, we need to close. We've got 5 minutes to close. This has been 1.5 hours of us talking.
It doesn't feel like it.
It's been a nice conversation. So thank you so much, Vimbai, for coming. Just to remind us that weight is never a simple issue, right? It's not just a story that we can just take for granted. It's a medical one, a human one. And on top of that, it's just a personal one. It's deeply personal. I'll just think that I'll just go and call Vimbai, and then the next day she's going to prescribe some drugs, some medication, and I move on. I'm going to talk to Nikki. She's going to direct me in the right way for things to just like that. No, it's a story, it's a journey. And I think the most important thing you said here, ladies, grace. Let's just give ourselves grace, self-compassion, self-care. We tend to forget ourselves, yet we are the ones who bear the brunt of these perimenopause. We move into menopause, and then we're in post-menopause. Bone density, muscle mass, all these things are on us, and yet everybody expects a little bit of us. So what do we do to make sure we take care of ourselves? So that's why we are here. And through the MyTano model of care, patients are really looked at as people, not just as problems to be solved. So that is what really I'm grateful for. So ladies, your midlife is not failing. It is biology. We were once young. I think there's so many songs about that. But we are here now.
But we want younger.
We were there, but now we are here. So you deserve care that just evolves with you. Wherever you are in your journey, whatever you look like, you do not necessarily have to just make a zela, struggle, shingirira, and it becomes misery.
Shipitisha for our Zambian family.
shipikisha, and then now you get resentful, and the cycle will continue like that because there's a lot of stress. When there is stress, all these hormonal imbalances will happen. So cortisol is also another, it's not a good thing to have because of all the stress that we have.
Stress.
Yeah. So let's figure out how to manage ourselves in menopause. Knowledge is power. That's why we decided to come today. And, just to mention that, the last thing that I want to just say is that you can reach out to us, to Vimbai, to myself. Here are our details, and I'm going to send it out to everybody. So if you want to just to just talk to us, these are our details. I'm going to post this this session on my podcast. It's on YouTube. That's the QR code. You can scan it. And also, I think MyTano has also put a QR code for the Instagram page. Please just feel free to utilize all those things because we are here for you. We are here to support you. Any last words, Vimbai, before we close?
Really, really grateful that we all showed up today. I think it's also a show of the shift in our attitudes as women. We spoke about our mothers. They also didn't have these tools that we have in 2026 where we can come together as women. I mean, imagine we are women from all over and with a shared purpose, with shared concerns, and we're able to come together and speak like this and have a nice conversation and hopefully help each other as we go through all that we're going. So, we love talking. I love talking. I will answer any questions. Talk to us. We are there. And most importantly, like I said, the one thing I also want you to all remember is grace and self-compassion. If you are able to give yourself grace and say, this is me, I'm still me, but this is just the changes that are coming. In the same way, when women are starting their periods, when we're having our babies, when we celebrate all those changes, why do we not celebrate this transition? It's fantastic.
Absolutely. So
I definitely can't wait to say bye to my period.
Mine is gone. So thank you, ladies, from the United States, from UK, from Zimbabwe, from South Africa, Zambia, Senegal, Kenya, Ghana, Nigeria. We represented and love you so much. Till next time. May you meet your body with grace, with softness, with just wisdom, your health, meet it with wisdom, and your future with power. Till next time. Bye. Bye.